is to treat a single type gingival recession in the lower jaw, and you see that the amount of keratinized tissue in the adjacent teeth is very thin to be used as a laterally moved flap. And so, since I have to make a bilaminar approach, namely a flap plus a connective tissue graft, I always prefer to take the flap from the keratinized tissue remaining apical to the gingival recession in order to make a first intention wound healing and not leave an area healing by secondary intention as it happens when you make a sliding flap. Obviously here we have some other problems like the presence of the frenulum. You can see here the presence of a shallow vestibulum depth, and you will see it after anesthesia. And this is why treatment in the lower incisors is much more challenging with respect to the treatment of upper jaw. Okay, now we make anesthesia. When you make anesthesia, you never make anesthesia in the area of the pedicle, so you are at the level. Cosa c'è? You are at the level of the canine.
Perfetto.
You bend your needle and you start with a very slow injection towards the area of the surgery. As much as you inject liquid inside, I increase the penetration depth of the needle, so it means that I'm taking my anesthetic to the area of the pedicle or to the area of the central incisors. Injection should be made always very slow, not to create trauma, vascular trauma, and also not to traumatize too much the lining mucosa of the lip. Now you can see that the needle is almost completely inside the tissue. It means that I'm taking anesthesia in the area of the pedicle. Tutto bene? You start to see that the lining mucosa of the lip is swelling. Lateral and canine on the other side, and we make the same thing.
Fammi così anche se no dopo si controlla la cara. sul computer non ce l'ho, però che tu nel tuo hard disk dovresti averne i filmati interi.
Non so interi. And also when you make anesthesia in the palate, you never have to make anesthesia at the level of the hard palate, but only, you see, at the level of the soft palate, because here the spread of the liquid is completely less painful and you don't make any perforation or vascular shock in the area that is going to be grafted. You see that in this area where the soft tissue of the palate is completely soft, there is no pain during the spread of the liquid, while if you make anesthesia in the area of the dense fibromucosa of the palate, especially in the area of the 7 of the 8 where we are going to take our graft in this patient, this is extremely painful because of the presence of very dense collagen-rich connective tissue. You don't have to make the oral anesthesia now, just to make let's say some anesthesia that will be reinforced at the time of the harvesting procedure, but at that time the patient will not feel anything more because anesthesia has already been done. Okay, this is more than enough of alveolar mucosa here that is attached to the root or to the bone. And this is the difference between lining mucosa. Può star fermo un secondo? No. Between lining mucosa and lining mucosa of the lip and alveolar mucosa. So when you're treating the lower jaw, the concept is to place always your surgical papilla trapezoidal in keratinized tissue. This is quite easy to be done here because you have a good amount of keratinized tissue, and also the vertical releasing incision should be extended for the moment, the less you can in alveolar mucosa. So this will improve your manipulation and your surgical elevation of the split thickness papilla. While the mesial papilla is much more difficult because you have less amount of keratinized tissue. Che è lei che trema, vero? Chiuda pure. Brava. Chiuda. Brava. And so I have to get as much as possible far from the mucosa of the frenulum, and so I have to place my surgical papilla much more cornal, and I will include also the frenulum in my flap design, otherwise the flap is too small to permit coverage of the connective tissue graft. Now that the flap design was made, I start with the split thickness elevation at the level of the papilla. The split thickness elevation of the papilla ends once you are able to elevate the whole papilla. Until you reach the probable area of the keratinized tissue. This is called split thickness papilla. Now we have to make the second split thickness surgical papilla, which is much more difficult because of the presence of the frenulum. Now, second
Logica, quando la fai fai e via.
This is a very difficult, tienimela dritta quel cavolo di incisione verticale, dai. Because we have the mucosa of the frenum, which is very, very close. Via, togliere. Okay, this is the second surgical papilla. Very unlucky, but we were able to give it the right shape, trapezoidal, and the same is for the second one. Now, I will extend a bit more. The vertical releasing incision in alveolar mucosa. And now I will elevate full thickness the small amount of keratinized tissue remaining apical to the gingival recession. Mi servono quelle da tunnel, lo scolatoio piccolino da tunnel. It's always important to have a perfect control of the bleeding from outside, because obviously you have such a thin tissue that they are really difficult to manage. So I use a very small periosteum elevator to make a full to make a full thickness elevation of the keratinized tissue epica qui, fisiologica. Ok. Vai, all'esterno, vai. Lì, continua, non mi aspiri, vada via. And I have to feel where is the bone crest. Right. And once the bone crest is reached, I can go again. Non so, oggi è una roba spicchia, tira. Again. Via. Dai, tirare. Parallel to the bone, deep incision, parallel to the bone, to detach completely the submucosal tissue, right, from the periosteum. And you see now the two papilla are above the lining mucosa of the lip, and they are still completely attached to the lip, right? Now it is important to change. So I will, sei dentro, stila dentro, non davanti a me. I will increase a bit the length of the vertical releasing incision on one side. And on the other side, in order to see very, very well the difference between deep incision and superficial incision, bene?
Mhm.
With this superficial incision, you are removing muscle from the inner aspect of the alveolar mucosa, so that you see that the muscles start to be isolated. Respirare qui, qui. Now that the lining mucosa of the lip, please look always at my surgical papillae physiological, that they are completely white in the inner aspect because there is only connective tissue, while the whole muscle is there. The problem is in this area is that this submucosal tissue is so coronally displaced due to the absence of the vestibulum depth that it's so close to the flap that you risk immediate shrinkage of the flap once it's coronally advanced. So there is one important difference now in the lower jaw, that is the removal of this tissue completely by making an incision perpendicular to the bone, perpendicular to the bone, perpendicular to the bone, and this is done also at the level of the vertical release incision in order to isolate and remove completely the submucosal tissue. This submucosal tissue is made of fatty, glandular, and muscles, and thanks to the removal of this tissue, we will expose only periosteum. In our vascular bed, right? Now you have to look at inside your bed. There is no more fatty, glandular, and muscle tissue, vital physiological. And you should see very carefully that the whole area is all of periosteum only, and the whole submucosa tissue must be removed cytospecifically from this area, not to have an early shrinkage of the flap once it will be repositioned coronal. Now the removal of the soft tissue has been made. We take a gauze, we start a small compression, and you have to see the verticality of the vestibulum depth that is being completely replaced. Luca, guardi questa linea di incisione, se lei me la tira troppo me la strappa, deve essere sempre un po' più al centro.
Metto vestibolare.
And you will see that thanks to the removal of this submucosal tissue, it will completely stop to bleed in a very few minutes. During time, you maintain a gauze compressed in apical direction, you expose the root, and you start with the root planing procedure. Gli date respirate un po' in bocca. With the gauze in position, you see how big is the bone dehiscence. 11, 12. I will make root planing only on the 3 mm coronal plus 1, which was the probing pocket depth, while the last 2 mm or even 3 of the bone dehiscence. You see that now almost completely stopped bleeding. You continue your compression with the gauze in order to isolate the root and make root planing in a very comfortable way. One, the dentin is completely prepared and it sounds healthy. It's time to apply for the ADTA gel, which is done to remove the smart layer from the dentin tubuli and improve blood clot adhesion. Now we can see the area with very good control of the bleeding because of the removal of the muscles and fatty and submucosal tissue. Now it's time for ADTA gel, which is applied on the root for 2 minutes. During the time the gel made its work, we can start with the desepithelialization of the anatomic papillae. We take another knife, apra leggermente. Inspire le papille. As I told you, we have to go with the knife to prepare the base of this. When the base is prepared, you can follow the cut with the scissors, but never before. You see that you need very long in order to reach the tip of the papilla as much as possible in one shot. Now the whole papilla is well prepared. We can remove the ADTA gel from the wound area. Girò per non tenere la ferita mentre non sul palazzo. You have to rinse with saline a lot in order to remove completely the ADTA gel from the dentin tubuli. And now you can see a very nice wound area with a good control of the bleeding, both at the level of the papilla and at the level of the surface, magari un po' più giù, fermo così, un po' meno labbro, così, ferma lì. Now it is time to measure how much graft I need. In medial distal dimension it will be 8 millimeters, while the apical cord apra bene. Now the patient does not feel anything because we made already anesthesia in this area before. Now, first of all, we design the grafted area.
Non ci vede davanti.
Così?
No, con la testa, mica con le mani.
Allora cambia la posizione. Non mi sta più bene.
Ok, aspetta.
Apra bene.
Vai. Aprire il massimo però, poi chiudi.
Non è che hai aiutato ad aprire perché lei chiude. Apra bene. Sente? Sente? Cacchio, non gli dica apra perché tanto lei non apre, quindi bisogna che gliela tenga lei la rimanita. After designing the distal vertical releasing incision, we checked for the measure. We said it should be 8 millimeters, and so we can make the second vertical releasing incision.
Aspetta. Vai.
Well, we define the graft thickness at the level of the mesial vertical releasing incision by getting in the horizontal
Tira giù.
and vertical. Apra grande.
Fa male a chi? Vabbè, dovevo oscurarmi.
Then we continue perpendicular and rotation, perpendicular rotation, perpendicular rotation, in order to give the graft the same thickness, apra grande grande, along the mesial vertical releasing incision. Now we reach the distal vertical releasing incision and we want to give the graft the same thickness. Now, apra grandissimo, I increase the depth of the incision distal in order to elevate also the distal vertical releasing incision like the mesial. Once the whole graft has been separated from the underlying tissue, it's time to connect the distal with the mesial vertical releasing incision. Say, yeah?
Sì.
By making the distal and apical incision superficial, and then you get deeper and deeper until the graft is removed. That's it. You see that there is no need of nothing because it does not bleed at all, because it's very superficial, but just to show you the management of this material, we apply it on the wound area of the same size of the graft. We make a mattress suture starting from distal to mesial. We turn around the buccal aspect of the corresponding tooth because there is no surgery on this tooth. Chissà che male. Poco, vero? O no? Molto? Un po', C'è la spinatina. Ma che deve essere così male? Stacca, prego. Lasciamo. Okay, now we go back to the palatal aspect.
Fatto bene?
And it's very important to close the knot. Torniamo come era prima. Distal and apical.
No, aiuta Katia, come prima lì.
Tengo la lingua.
La mandibola, come
Apri
prima.
Come
Così va bene?
Così va benissimo.
Okay. The knot should be closed distal and apical, so we can block any vessel coming from distal and apical, and at the same time we can stabilize with a compressive suture the collagen substitute. Now we check with the gold by compressing a bit if there is need for something else. Apra. You see that everything is absolutely stable, and we will see also the wound area at the end of the surgery. Now, apra bene un attimo, ferma così, bene? The patient can rest. This is the inner aspect of the graft. You see it's completely white. There is no need to remove any fatty and glandular tissue, so we can immediately go back to the desepithelialization. We use just a drop of saline to make the cut. We take the right thickness to be removed, and when you see the epithelium of the knife, you go parallel in order to remove it completely in one shot. The second cut should be made in the most apical aspect of the graft to remove some remnants of the epithelium here. While the third cut should be made in the most coronal aspect where we will come back. Now you turn your graft. Now the apical aspect. Now don't forget to make the cut perpendicular in order to remove some remnants of epithelium in the most coronal aspect where you made the perpendicular and rotation approach. And so you keep it firm. You make this very, very sharp incision in order to remove remnants of epithelium. Now if you look at the graft from the occlusal aspect, you can see that it's exactly the same from the mesial to the distal, and its thickness, it's about 1 millimeter, even less. We are about 1 millimeter, but it is less thick in the periphery where we are going to place our graft at the level of the papilla. Now we go back to the patient. Now we place our graft and the graft should be placed at the level of the cement enamel junction, and you see how it well follows the buccal root, despite it's buccally dislocated, but at the same time it well adapts to the baseline of the desepithelialized papillae. Now we take the short needle, and it's very important to get inside.
Excuse me,
You don't cane.
you don't need to place any endogain before?
No, because endogain should be placed only when you have very, very wide buccally dislocated root. In this case it's not so, let's say, yeah, you can also apply it, doesn't matter too much.
Did it happen if you left some remnants of epithelium beneath the flap, on the graft, I mean?
If it's only some remnants, nothing happened, because the first healing process of the graft is the desepithelialization. So they will be removed by themselves. If you leave the old epithelium, it's a problem. It's very important to fix the note. Questo è quello di ottobre.
Sì, era quello di ottobre.
Vai con la fisiologia. To fix the note, of the suture material.
Quella di gennaio.
No. Right. Where is the graft, so that you are sure that the all anatomic papilla disepithelialized are completely free for the surgical papilla of the corneal advanced flap. Okay, now you see that the graft was placed in position like la fisiologica. Vai, su.
Vogliamo fare una foto?
Sì, facciamo con un'immagine occlusale. You see that the graft does not reach the most apical extension of the root exposure, and this is not necessary. Volevo toglierti il sangue da qui, togli il sangue da qui. I want to show you that there is some root that is exposed apically, and this does not influence at all the healing process. Basta. The graft is applied at the level of the cementinamide junction, at the level of the root with respect to the papilla, where we don't have to interfere at all with the healing process of the surgical above the anatomic papilla. Okay, ferma. Papilla. So in the final position they have to be sutured.
Fai con seria prima.
Mm-hmm. And in this position you keep the lip in order to maintain the papilla in the final position. This is very important. And now we make a stabilizing suture. Tieni qui il labbro spinto come faccio io. Così. Which is not the final suture, because this suture will be repeated at the end once the vertical releasing incision has been completely closed. This is just to position the papilla in the final position, so we take surgical, anatomic, sentila appena, anatomic papilla, appena, bravissima, così, below the contact point, chiude pure un po', si vede? Again, surgical, anatomic papilla, I will check for the compression of the suture material in the middle. Then I go back at the starting point. And now I close. I don't want to achieve ischemia in this case. I just want to position, to have the final position of the papilla aspecta in place. Right? Because this suture is very important to allow me to make the suturing along the vertical releasing incision with the papilla in the final position once the lip is very, very close. Now, lascia. You see that I can pull my lip and I can use again the elastic fibers of the lining mucosa to give verticality to the vestibulum depth. At the same time, the papilla remain in position. So I take my mucosa, periosteum, adjacent soft tissue. No.
Così no.
Così?
No. Non c'è, come bisogna basta tirare un pelo poi.
Aspetta un secondo. Aiutami un po' dall'altro lato, dai. So we take the alveolar mucosa, periosteum, adjacent soft tissue. And now it's very important to fix this note in apical direction. Tira un po' più di là. No, senza farlo gonfiare, giù.
Non è,
No, è venuto malissimo.
non sembra stretto al massimo.
Come se fosse la prima volta che lo facciamo. Tieni, dai. Verso il basso. E dai la struttura. Che un cazzo. This has to be done really correct, otherwise it doesn't work. Lascia così, così. The problem is that you have to see allora tieni solo così un attimo, così. Se vedi niente, tu prova a fargli vedere appena, non dovreste tirare giù verso il basso.
Così si vede. Togli solo la tua testa che occupa la luce. Qui dall'alto così devi tirare.
Sì.
Aspetta un secondo.
Thanks to the anchorage of the periosteum. The vestibulum that verticality should be replaced. Now the second one, which is equally important, that is the distal one. From the flat periosteum
No, sono sottili.
Cioè, gli ho detto di tenere o di spirare? It's very important to take the periosteum here and again. Ok, così va bene. Ferma lì. Ok, I have to take the periosteum here. Vedi? And at the same time the adjacent soft tissue in order to block also the base of this pedicle. And now the verticality of the vestibulum that can be rebuilt. Now I will come.
Non guardiamo in faccia la malizia.
Abbiamo perso anche questo allora. Mi spieghi perché parlano in continuazione?
Cultura.
Now it's very important to complete the suturing along the vertical release incision in every single micron. Of your flap, in this case with the intramural suture, but by using the attached gingiva of the adjacent teeth. You see, if you want to speak to me, please speak. If you are speaking by yourself, you can also leave the room. Se ne sbattono.
Una volta usare la seta in questi libri.
Non si faceva per pallone. Non si faceva per pallone. Tu hai mai visto trattare gli incisivi inferiori se non con degli innesti liberi? Vedi con che violenza la carta aspira, vero?
No, io sto tirando sul dente, da quello. Non so da prendere.
You remember that there was a frenulum here, there was a very big tension of the lip. Now I'm able to make this suturing very comfortable with the vestibulum depth that it is completely being replaced and the papilla are in the right position. Now we're starting with the distal vertical release incision, with the mesial vertical release incision in the same manner. Intramural from the flap. Non staccarne il lembo da lì.
Lascia.
No, lì.
Aspira prima.
Si deve sempre un po' più attaccato, Così. Right. You see that there is sometimes some bleeding escaping from the soft tissue margin, and this is something that we have to solve with the last suture. That is that one that it will adapt as a cord the keratinized tissue to the convexity of the clinical crown. Because the first suture I did, the sling one, was only used to fix the papilla in position, not to obtain stabilization of the blood flow.
very calm.
Okay, lasciami. Physiological. Now you can see that the vestibulum depth is completely replaced. Non vedo. Again, we have the lining mucosa of the lip, which is almost perpendicular, but we have enormous amount of alveolar mucosa, which is covering the connective tissue graft in the right position. Now it's only time to make stability of the blood clot and repeat the coronal suture by changing the position of the knot. So we take back the 11 millimeter needle. Did I have physiological? No, physiological. And with the same papilla in position like this, like we did before, you see that there is some bleeding getting out from the soft tissue margin. You see it? See? So it means that the coagulum will not be stable. It means that we have to repeat now that everything is perfectly stable, the first suture in order to fix the keratinized tissue to convexity of the clinical crown and give stability. Look how much liquid is getting out when I pull the lip from the soft tissue margin. So keep here. Oh! Qui. Lasciami un attimo, lasciami così. Uno di qua, uno, no, basta uno solo che tenga l'abito. Ok, così. Attaccato al lato. Dov'è? Qui e qui. In order to place only one knot in each papilla, I change the position of the knot. The first knot was positioned at this papilla. Now I take this papilla and I make the same suturing, surgical, anatomic papilla. Leggermente aperto. Palato. Below the contact point at the mesial papilla. Chiudo appena. Again, surgical anatomic papilla, a bit more apical with respect to the first starting point. Check the compression in the middle. And now, when I close, I have to pull. Chiudo ancora un pochino. Ci sei? Ti fermo, vai. I have to see that there is no more bleeding from the soft tissue margin, so I check for this and I close it. Now saline, the physiological, and I have to check that once this coagulum is being removed from the soft tissue margin, there is no other blood coming out. Ferma. Otherwise, if there is some small bleeding getting out, it means that I have to pull it a bit more. And that's why I cannot use a monofilament here, and the risk is to cut the papilla. Now, once stability has been achieved, I close the knot. Yeah, lasciato me. Fisiologica. Now you have to stay here, with the lip in tension, chiuda pure, and you have to check that there is no more bleeding getting out from the soft tissue margin. When I pull the lip, there is no bleeding escaping from the soft tissue margin. It means that I really reach adaptation like a cord of the keratinized tissue to the convexity of the clinical crown. The root is covered in excess with the keratinized tissue, and the verticality of the vestibulum depth is replaced by the flap. It will be the graft that will give this verticality a long-term stability. Now I will show you absolutely parallel to the bone, parallel to the adjacent keratinized tissue, while the lip is still horizontal. So where does this alveolar mucosa comes from? Where is the frenulum, which was absolutely attached to the mesial surgical papilla? Where are they now? They are no more present because I used the aligning mucosa of the lip and I transformed it in the alveolar mucosa to cover the connective tissue graft. Apra appena appena. You see that even if I pull the lip, this verticality is completely maintained and there is no bleeding escaping from the soft tissue margin at all. And you see that the wound area is really, really, really very small and there is no problem at all because the connective tissue graft was so superficial. So this is really the most